Hello, welcome to this basic cardiac telemetry series. Today we'll talk about sinoatrial rhythms. To make sense of an EKG, these are the structures to remember: the sinoatrial node, the AV junction, the bundle branches, and the Purkinje fibers. The sinoatrial node is located in the right atrium near the opening of the superior vena cava. This is a collection of specialized cells that is able to generate the electrical signal to initiate the heartbeat. The sinus node is the natural pacemaker of the human body. From here, the electrical signals spread from the right atrium to the left atrium. This makes the right and left atria contract and pump blood to the ventricles. The electrical signals then reaches another special conducting tissue, the AV junction. The AV junction is at the base of the wall dividing the atria or the interatrial septum. The AV junction is composed of the upper part, the AV node, and the lower part, the bundle of His or the common bundle. The AV junction is the electrical connection of the atria and the ventricles. It is like a relay station. In the AV node, there is some delay in the electrical signal to allow the atrium to pump blood to the ventricles and allow the ventricles to fill blood. The signal is then transmitted to the bundle of His, which then divides into two branches, the right and left bundle branches. There is one right bundle branch and two left bundle branches, or the left anterior fascicle and the left posterior fascicle. The electrical signal reaches the ventricle via the Purkinje fibers. The signal then spreads in the heart muscles or the myocardium, going toward the outer part of the heart or the endocardium. The electrical currents are then recorded by electrogram via the electrodes. Simplistically, the direction of the cardiac electrical impulse is from the right upper part of the body going to the left lower part of the body. To record this, stickers or electrodes placed on the patient attached to wires are connected to a machine or telemetry boxes. On the EKG machine or telemetry monitor, this electrical signal is displayed in what is called leads. These leads record the electrical voltage of the heart. The leads are like several individuals watching a baseball game. They are positioned at different areas of the stadium. In routine telemetry, the 6-limb lead plus 1 or 2 chest leads are used. The two groups of limb leads are bipolar limb leads 1, 2, and 3, and augmented unipolar limb leads AVR, AVL, and AVF. Because there is so much patients to be monitored, only 1 or 2 leads are used or displayed for arrhythmia monitoring. The electrodes are attached to the extremities when doing the 12 lead or in the body for telemetry monitoring. In most EKG rhythm tests or arrhythmia recognition tests, lead 2 is used. Lead 2 record the voltage difference between the right arm and the left leg, with a positive pole on the left leg. As a general rule, an impulse going to the positive pole of a lead will create a positive or upright EKG deflection. So lead 2 will generate a positive deflection because the cardiac electrical impulse is moving from the right upper to the left lower part of the body, or towards the positive pole of lead 2. For AVR, the complexes are predominantly negative because the impulse is traveling away its positive pole. Normal sinus rhythm is an impulse that originates in the sinus node. It is recognized by the P-wave morphology that is upright with an upright P in leads 1, 2, and AVF. It is inverted in AVR. It is variable in leads 3 and AVL. If you have a 12-lead EKG, it is upright in leads V4 to V6. And it is most often biphasic or positive then negative in leads V1 and V2, with some minor variations in morphology related to respiratory cycle. For EKG test-taking purposes, an upright P wave in lead 2 is basically sinus rhythm. The PR interval exceeds 1 0.12 seconds and can vary slightly with rate. And the rate can be between 60 to 100 beats per minute. Most cardiologists agree that the operational limit for normal sinus rhythm will range from 50 to 90 beats per minute. And rates lower than 60 beats per minute are considered to be sinus bradycardia, and rates higher than 100 beats per minute are considered to be sinus tachycardia. Now, caution. During some AV blocks, which will be discussed in some later posts, the sinus P waves are not followed by a QRS. The atrial rate, which is computed by using the PP interval, is higher than the ventricular rate. So the sinus rate is the basis for interpreting whether it is sinus bradycardia or sinus tachycardia. So you will see interpretations like sinus tachycardia with second degree AV block type 2 with ventricular rates in the 50s, or sinus rhythm with a complete heart block with idioventricular escape with ventricular rates in the 30s. This is a full disclosure of the patient in telemetry. It shows all limb leads 1, 2, 3, AVR, AVL, AVF, and the V lead. The P wave has a sinus node morphology being upright in 1, 2, and AVF, and inverted in AVR. In EKG rhythm test, the leads commonly shown will be lead 2 and also V1. So this is sinus rhythm with a bundle branch block. The sinus P wave, the P wave is upright in lead 2, followed by a wide QRS around 0.12 seconds with a QS pattern in V1 with a rate of about 75 beats per minute. This is also sinus rhythm with a bundle branch block. The P wave was upright in lead 2, followed by wide QRS with a QR pattern in V1 at a rate of about 93 beats per minute. And nice to know, bundle branch block can either be left bundle branch block, LBBB, or right bundle branch block, RBBB. There are certain criteria to make bundle branch block interpretation. However, generally by looking at B1, if the QRS is predominantly negative, then the block is most likely LBBB, or left bundle branch block. And if the QRS is predominantly positive, then most likely it's RBBB, or right bundle branch block. This is sinus bradycardia. This P wave is upright in lead 2, followed by an narrow QRS with a PR interval of 0.16 seconds. The atrial and ventricular rates are about 38 beats per minute. This is sinus bradycardia with a bundle branch block. This is lead 2 and V1. The P wave is upright in lead 2, followed by a wide QRS with a QR pattern in V1. The PR interval is about 0.20 seconds. There is 1:1 atrial to ventricular ratio of a rate of 56 beats per minute. This is sinus tachycardia. The P wave is upright in lead 2, followed by a narrow QRS. The P wave here is seen right after the T wave. The rate is about 150 beats per minute. This is sinus tachycardia with a bundle branch block. The P wave is upright in lead 2, followed by a wide QRS with a QS pattern in V1. The P wave is partly merged with the T wave, and the rate is about 115 beats per minute. Sinus arrhythmia. It is recognized on the surface EKG being a rhythm that is irregular. The P wave and the PR interval are normal. The P to P interval varies by 0.16 seconds or 4 small squares. So, strictly speaking, not all irregular sinus rhythm is sinus arrhythmia. Now, an EKG test tip. Most basic EKG tests would classify any irregular rhythm as sinus arrhythmia. If you are taking the test in a computer and the rhythm is irregular with sinus P wave, then choose sinus arrhythmia among the choices. If it is a paper test and it will be checked by a person and not a multiple choice test, then you can argue that it is sinus arrhythmia or just sinus rhythm basing on the above criteria. And nice to know, there are 3 types of sinus arrhythmia: phasic or respiratory sinus arrhythmia, non-phasic or non-respiratory sinus arrhythmia, and ventriloquiophasic sinus arrhythmia. With phase 6 sinus arrhythmia, the rate is dependent on the respiratory cycle, increasing with respiration and decreasing with expiration. The pacemaker site in the sinoatrial node shifts with respiration. The pacemaker site shifts higher the SA node, and the heart rate and the P wave amplitude or size in 2, 3, and AVF increase. As the pacemaker shifts lower the sinoatrial node, the P wave amplitude and heart rate decrease. The heart rate changes gradually and rhythmically, thus differentiating it from non-phase 6 sinus arrhythmia. So this strip is phase 6 sinus arrhythmia. The rhythm is irregular. The P wave is prominent at the beginning, but there is a decrease in amplitude or size as the rate decreases. For non-phase 6 or non-respiratory sinus arrhythmia, the P wave and the PR interval are normal, but the PP intervals vary at random and independent of any physiological function. Now for this strip, which is a non-phase 6 sinus arrhythmia, the rhythm is irregular with upright P waves and normal PR interval. At a higher rate, the P wave is more prominent compared to the lower rate. For ventricular phase 6 sinus arrhythmia, the P to P interval encompassing a QRS complex are shorter than the intervals without an intervening QRS complex. Ventricular phase 6 sinus arrhythmia is noted in the presence of AV block. In this strip, the rhythm is still sinus because there are upright P waves seen in lead 2. The atrial rate is about 88 beats per minute with second degree AV block type 2 or Mobitz 2, manifesting as 2 to 1 and a 3 to 2 AV conduction. The P to P interval encompassing a QRS is shorter compared to that without an intervening QRS, which is 0.68 second versus 0.76 second. Wandering atrial pacemaker, or WAP. WAP is a variant of sinus arrhythmia. There is a passive transfer of dominant pacemaker focus from the sinus node to latent pacemakers. The change in P wave shape occurs gradually, and there is only one pacemaker that is controlled. It is recognized on the surface EKG as a change in P wave contour or shape, which is gradual, and after several cycles, the pacemaker shifts back to the sinus node. Do not confuse WAP with multifocal atrial rhythm. So in this strip, this is wandering atrial pacemaker. These two strips are 10 seconds long in long lead 2 that are seconds apart that were intentionally printed to illustrate the gradual change of P wave contour or morphology. Thank you and have a good day.